Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is July 2nd, 2025. This video is on a paper, state-of-the-art review, published in the European Heart Journal, titled Refractory Angina, Mechanisms and Stratified Treatment in Obstructive and Non-Obstructive Chronic Myocardial Ischemic Syndromes. We are delving into a condition that leaves patients with a heavy chest and doctors baffled. That's refractory angina. For years, it has been defined too narrowly. But what if the chest pain puzzle has more pieces than we thought? Beyond the blockages, a new definition emerges. Refractory angina used to mean chest pain despite medications and procedures in obstructive coronary artery disease. It now includes patients with ischemia without obstructive coronary artery disease, the INOCA and the ANOCA groups, symptoms post-PCI or CABG, and those with coronary microvascular dysfunction, vasospasm, or myocardial bridging. The new definition: persistent angina for at least 6 months despite maxed out therapy and revascularization with demonstrable ischemia from any coronary compartment. The hidden burden: in the US, up to 1.8 million patients may suffer from refractory angina. The economic toll is staggering, $21 billion for INOCA annually. Many are misdiagnosed, misclassified, and mistreated. Why? Because our old lens focused only on blockages. The result: delayed diagnoses, unnecessary procedures, and a quality of life crisis. Ischemia has many faces. So what really causes the pain? Epicardial coronary artery disease, it's the classical blockage. In CMD, it's coronary microvascular dysfunction. Vasospasm from hyperreactive smooth muscle. Myocardial bridging, the vessels tunneled within the muscle. These can occur alone or in combination. And that's why the term refractory needs more nuance. Diagnostics, the full toolbox. Time to rethink how we investigate. Invasive includes fractional flow reserve, coronary flow reserve, wire-based pressure and flow reserves, acetylcholine testing for spasm, IVUS, and optical coherence tomography for bridging. Non-invasive, PET is the gold standard for coronary flow and reserve, CMR for perfusion, fibrosis, and function, stress echo, Doppler, CFVR, flow reserve, angiography-derived metrics. Also emerging, angiography-derived physiology and AI-based flow mapping. Only with the right diagnosis can we tailor the right therapy. Drugs that don't shoot in the dark. One size fits all doesn't work for obstructive coronary artery disease. Beta blockers, calcium channel blockers, and ranolazine. For coronary microvascular dysfunctions, stratified therapy per CORMICA trial. Ranolazine helps if coronary flow reserve is less than 2.5. For vasospasm, calcium channel blockers are the first line. Consider nicorandil or Rho kinase inhibitors. For myocardial bridging, beta blockers or calcium channel blockers. Avoid nitrates. Treat the mechanism, not the morphology. When pills aren't enough, consider devices and biologics. What happens when the meds fail? CSR or coronary sinus reducer, it's a class 2B indication, shown to reduce angina in COSIRA and ORBITA cosmic trials. EECP, that's enhanced external counterpulsation. Non-invasive, helps collateral flow. ECSWT, shockwave therapy to boost microvascular perfusion. Biologic like CD34 cells and VEGF factors are still investigational but promising. Enter the Angina Heart Team. Managing refractory angina isn't a solo act, it needs an orchestra. cardiologists, imaging experts, pain specialists, psychologists, patient-centered care, and tailored therapy will require reassessment, re-stratification, and sometimes reinvention. They enable personalized, iterative care pathways for complex refractory angina cases. Refractory but not resigned. Refractory does not mean untreatable. Expanded definitions, advanced diagnostics, and stratified therapeutics are rewriting the care. Even stubborn chest pain has a story and a solution. More details in this comprehensive state-of-the-art review. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.